Good evening. I'm Dr. Patrick Crane, Assistant Professor at the MSU College of Nursing. It's my pleasure tonight to moderate this broadcast of Conversations, a series of webinars sponsored by the College of Nursing. The topic today is caring for individuals with dementia and will be presented by Drs. Linda Keilman and Leslie Simons. Let me begin with the provider disclosure statement. Our speakers attest that no financial relationship exists between themselves and any other commercial supporting entity which would represent a conflict of interest or commercialize any presentation content. There are no CEUs available for today's presentation. I encourage everyone to type their questions into the Q&A box throughout the presentation. There will be time for questions and answers at the end of the presentation when Drs. Keilman and Simons finish. Dr. Keilman, welcome.
Thank you, Patrick. I am happy to be here and welcome everybody that is attending our talk this evening. And what we really want to start out our talk with a general overview of dementia. There is a lot of misinformation out there, so that's how we want to set the foundation for this evening. So as we age, our bodies change in many ways, including the brain. Our parts are less efficient and effective for a number of reasons that are considered either normal or usual changes of aging. The older we are, the more changes. This is unique for everyone, depending on our genetics, lifestyle, the environment in which we live, and who we are as individuals. Have you ever had a tip of the tongue moment when you knew the answer but just could not get it out? That's normal. Thank goodness, because I have those all the time. I'm still trying to think of who was the actor that played the King of Siam in the original Rodgers and Hammerstein movie, The King and I. It's really sad, isn't it? I can remember lots of stuff about it except the person's name, but I know I will get it eventually. So the tip of the tongue things are really about cognitive aging, the age-related changes and how the brain manages memory, thinking, and other mental processes. So today I wanted to share with you about the deviation from normal of the brain and focus on the neurodegenerative disorder called dementia. So dementia is a general term for loss of memory and other mental abilities severe enough to interfere with daily life. Dementia is caused by physical changes in the brain and a variety of diseases and conditions that result in damaged brain cells or damage to the connection between brain cells. Dementia is a prolonged condition with a significant time span between symptom appearance and death, and I'll talk a little bit about that later. So the usual or normal changes in cognition or thinking with age include, it's more difficult to recall on demand. As I just told you, I can't think of the name of the actor who was in King and I, but I will. We also require more time to learn something new. I need to get a new cell phone, but I don't want to learn all the new things. It's been like 5 years, so I know there's a lot of changes. I know I can learn them. I'm just kind of lazy. Or new computer programs. The other usual or normal change is multitasking becomes more difficult. It's really best to do one thing at a time. You know, it's kind of like when you go to another room to get something and you get there and it's like, what am I here for? And then I don't know what your process is, but I usually go back to where I started from. And most of the time it'll hit me why I wasn't there. So what's important to understand about normal brain aging is it does not impact day-to-day function, nor does it affect our core abilities that we learn and use over time. So Bottom line, dementia is a clinical brain syndrome, not a specific disease. Short-term memory is surprisingly brief, typically lasting 20 to 30 seconds. That is why people with dementia ask the same questions or tell the same stories over and over. They don't remember, they just did that. Long-term memory can be surprisingly stable, with memories lasting years and even decades. Why, at some point in the process, the person does not recognize who we are or our role, like spouse or sibling, is because they are no longer in the time frame of their actual age. They have gone back, perhaps decades, to a time where if I tell my mother now I'm her daughter, she thinks she's in her 40s. So she just laughs and she knows you are crazy. So I'm like, oh, okay, maybe I'm not. But it's just the way our brain works. Our memory can also be surprisingly fragile and fallible. Sometimes we forget. Other times we're subject to misinformation effects that can even lead to formation of false memories. So my brothers and I were talking, this is a number of years ago, about something we remembered when growing up. It was learning how to ice skate. And my dad was in the room with us, and um, after we were just laughing and having these great memories. And then all of a sudden, my dad said to us that he would love to meet our parents sometime. What does that mean? Well, either our perceptions or his were not reality, but that's what happens. Cognition is the term that refers to the mental processes involved in gaining knowledge and comprehension. These are also higher functions of the brain, which encompass language, imagination, perception, and planning. So I just want to point out a couple areas of the brain that are related to some of the dementias. So this is a very simple handout, and I'm sorry, diagram, and we do have a handout for you, and this is in there so that you will be able to look at it afterwards. So whereas dementia and other conditions cause neurons to become badly damaged and eventually die, in a normal older person with cognitive aging, the brain's neurons are basically okay. They're just working less quickly and less well than earlier in life. So although cognitive aging does not cause certain mental processes to happen less quickly, normal cognitive aging should not impair an older person's abilities to the point that they are visibly struggling with performing life tasks or no longer able to live independently. So if we look at the frontal lobe, which is the pink section, it's involved with our personality, behavior, and emotions. Frontotemporal dementia, or FTD, affects this area of the brain. The temporal lobe, or the yellow, helps us understand things we see and hear around us. It's involved with remembering, recognizing faces, objects, and scenes. It's also involved in language, including naming things and remembering words. So the temporal lobe also has a big role in memory. Inside the temporal lobe, if we sliced off a piece, there's an area inside called the hippocampus where new memories are made. And it also helps us find our way, remembering places and layouts. This area is affected by Alzheimer's dementia. And one of the things that happens is people forget common words, so they have word finding difficulty. And also we hear a lot from families that, or the individual, that they went to their church that they've attended for 40 years, but didn't really realize what they were supposed to do when they get there. So it's really about where the disease takes place in the brain. So I talked about the brain filling in when we don't have all our memories, but elaboration happens when we're struggling to remember something. When the information cannot be recalled, the brain sometimes fills in the missing data with whatever seems to fit. So that's how our brain tries to compensate for us. And that's why sometimes people don't make sense. So memory is really a broad category. And it covers our ability to remember information. So there's working memory, which refers to the ability to temporarily hold information in our mind and manipulate it. Like when we learn a new phone number and then we can dial it. Or if I asked you to remember 3 words, car, nickel, pony, would you be able to do that? There's also semantic or long-term memory. This involves really the things that we experience and live over a lifetime. Things that we should remember because perhaps we learned them when we were young, such as the name of a state capital. Episodic memory really refers to one's memory for personally experienced events that have happened at a particular place or time during their lifespan. Prospective memory is really the ability to remember to do things in the future. So why we have calendars, so that we write something down, we should be able to remember it. Or procedural memory. This is also known as skill learning, and that really refers to remembering how to do certain activities like brush our teeth, get out of bed, dress appropriately. It usually requires time and practice to build up. So if you think about children, they learn to eat and drink before they really learn how to dress themselves or put on their shoes or tie their shoes. That takes a little bit longer. But with the memory, there's so many things involved. And when you look at your handout, you'll be able to see all those things. And oops, sorry. Dementia is not normal aging. If nothing else, I hope that you learn that. It also impacts the whole person, the biological, psychological, social, spiritual, cultural, and environmental impact. And it also is about family and care partners and friends. And it starts subtly, then begins to interfere in daily life functioning. And it's chronic and progressive in nature. And at this time, there is no cure. But one thing I want you to remember too is that as older adults, we're all unique. We all have our personalities. We all have things that make us happy, ways that we have fun, ways that we engage with the world. So we never assume that a loss of mental sharpness is just a normal sign of aging. I really get concerned when I have older patients or their families tell me that they've had these symptoms for several years and their primary care provider would just tell them, you're 80, what do you expect? You're old. That is not acceptable. So I would like you to remember about dementia related to it being an umbrella term, referring to many types of dementia. There's over 21 different types of dementia. Each dementia has somewhat of a predictable course of decline, but it has unpredictable episodes of exacerbations and relative stability. So if you look at the umbrella, the handle, the main frame is really Alzheimer's disease. It's the most common. Then we have vascular dementia. We have mixed dementia, which can be Alzheimer's and vascular, Alzheimer's and Lewy body dementia. We also have the frontal temporal lobe dementia, Parkinson's disease, etc. I think it's also important to remember that culturally, Latinx population is 1.5 times higher in developing dementia than whites, and African Americans have a 2/3 risk greater than whites in developing dementia. I also think that it's important to understand that more women than men have dementia. However, women live longer than men, so that is part of the reason. But some facts, again, I'm going to highlight that dementia increases with age, but it's not normal. And an estimated 6.2 million Americans age 65 and older are living with Alzheimer's dementia in 2021. 72% of those individuals are age 65 and older. So the longer you live, the higher risk you are for developing a dementia. People age 65 and older survive an average of 4 to 8 years after a diagnosis, yet some can live as long as 20 years. This actually reflects and should help us understand that the syndrome is very slow and it takes a while. And there's 7.7 million new cases every year of dementia worldwide. That is truly significant. And just talking a little bit about the costs, there's 6.2 million caregivers that are family or non-paid in this country, taking care of people with dementia and generally Alzheimer's. And $256.7 billion worth of care is provided by family members and other unpaid caregivers. That's totally amazing. And yet, Medicare and Medicaid do pay out some costs, but if we don't learn and do more research in trying to develop a treatment to slow, stop, or prevent dementia, it is predicted that in 2050, Alzheimer's is projected to cost more than $1.1 trillion a year, and that's in United States dollars. And that's not counting all the other dementias. So it is a costly disease. I also want you to understand that there are symptoms that a person may have that is not dementia. It can be diagnosed inappropriately, but there are potentially reversible causes. This happens a lot in the hospital after anesthesia. It's medications that stay in older adults' bodies much longer than they do in younger adults. So they act confused, they act strange, they're different. And a lot of times they're diagnosed with dementia when really what they have is delirium, which is an acute or quick onset that changes their personality, their level of confusion. We need to look for reversible causes. Drugs, vitamin deficiencies such as B12, D, medications. Medications can interact with one another. Infections. A person who acts confused could have a urinary tract infection or an upper respiratory infection. The hypothalamus, which actually is like the thermometer of the body, that changes and wears out as we age as well. So by the time an older adult has a temperature of 99.9, they probably have a raging infection going on. So we cannot utilize temperature as a marker. So I want you to understand too that every individual living with dementia has their own story. They have a name, they have a history, they have personal experience. And everyone with the brain is at risk for developing dementia. The risk factors, the highest are age, advancing age, genetics for some, we know have found several genes for Alzheimer's dementia, and a family history. So screening is the most appropriate way to detect types of dementia. And early detection may be able to allow intervention to ameliorate or delay the onset of symptoms. And this can also improve quality of life for both the person with dementia and their loved ones. While there is currently no cure for dementia, there are several medications that can help treat symptoms. Knowing sooner can also allow individuals to make many important decisions, such as planning for the future, long-term care, organizing estate affairs, trying to have their voice still be able to be heard when they're in an end-stage dementia, and have a patient advocate that will follow what their wishes were. I put this little table in for you, and it's in the handout, that Alzheimer's is the most common, as I said, then vascular, Lewy body, and the frontotemporal. And you can read more about those when you have your handout. So what I would like to tell you about communicating with individuals with Alzheimer's dementia is we should never argue. We should agree. It doesn't matter whether they think that it's 1950. It doesn't matter whether they think they're in Florida. It doesn't matter. And if we argue with them, it causes behavior issues. Never reason, divert instead. Never shame, distract. Never lecture. I answered that question for you 5 times already. They don't remember. Short-term memory, 20, 30 seconds. Reassure them. Just keep answering or change the subject. Never say remember. This is what they can't do. They can't remember. Reminisce with them. Never say I told you so. Instead, repeat or regroup. Never say you can't, because there's a lot of things they can't do. As we get older, there's a lot of things that all of us can't do. So concentrate on what they can do. Operate from a strength-based model. Everybody has a strength. We might have to think about it, but we can find it. Never command or demand. Instead, ask or role model what you want them to do. Never condescend, always encourage, and never force. Instead, reinforce. And always remember that every individual living with dementia is unique. They have their own past. They have their own life story. And that's what we need to remember about the individual, who they were before they developed a dementia. So I am now going to turn this portion over to Dr. Simons.
Hello, everyone. I am Leslie Simons, and my portion of this presentation is communication with those with either dementia or Alzheimer's disease. Go ahead, Linda. Okay. So in practice, I work a lot with older adults. I had worked in a pain clinic for many years as a nurse practitioner, and now I work in a headache clinic. And it's important when you have someone that's older, maybe a little bit confused, you want to ask permission to sit down with them. And that is even with families or friends. You want to be at eye level, and you want to face the individual and ask where you should sit before you sit down, because they may have something in their mind that they want you to sit in a specific spot. For the patients that I work with and my family members, I always either sit on a stool if I have someone who is in a wheelchair and their head may be down and they won't lift it. I've actually got down on my knees and looked up into their face to talk to them, just so that I can find some sort of connection with that person. And typically they'll look at you. You sometimes may have to, they're looking at you and you don't have an idea what they're thinking, but sometimes a hand will come out and they'll put their hand on your face or your shoulder and just look at you. Other times you have to be careful because you might get hit and you don't know that, but just remain calm and work with it. Respect the dignity of the older adult as an equal and as an adult. And you should speak directly to that person. And I do that in practice. Family members, I know, are very concerned. They want to give you the information, but it's amazing sometimes what these people remember. I had a patient in the pain clinic who her assistive person was with her and said, oh, she doesn't even know why she's here. And I thought about that for a minute and I asked her, do you know why you're here? And out came the most coherent answer. She knew exactly why she was there. And she also told me that her doctor told her to come there to get her back pain looked at. So you never know. There is a person in there. Try and make the person comfortable. If you're walking with them, you might want to offer an arm or an elbow for balance. And then also you're looking at them and considering whether they appear ill or how they're feeling right now. And you can get some really good visual clues by looking at the way they're sitting, if they withdraw when you sit down next to them, and you're just kind of feeling your way. You might ask them this question, how they feel, and sometimes they will tell you, or sometimes they may look at you and go, well, how do you think I feel? So you have to kind of be prepared for whatever the answer is. And as a provider, we are always very busy, but I slow down and allow some quiet time. I don't talk very slow, but I sometimes will lower my voice and not gesture a lot. I talk with my hands, and sometimes that can be frightening to someone with dementia. And looking at these pictures, it's the nonverbal communication part that you're looking at. The woman at the top of the screen with her hands on her head may just be thinking this is how she sits and it's comfortable for her, or she may be confused, she may be upset, she may not know where she is, and that takes some real quiet communication. The gentleman to her right with the green shirt, this can be the way he normally talks, or he's really, really frustrated. And he could be saying, everyone asks me the same questions over and over and over. How many times do I have to tell you? So you just kind of sit back and say that sometimes you don't have to say anything at all. And sometimes you just say, well, I just kind of wanted to know how you're doing and learn a little bit about you. You want to make sure you're maintaining eye contact with them. And you also have to take into consideration, if you have your head down and you're talking to an older adult, not only they might have dementia, but they might have hearing loss and they won't be able to hear you. You have to look them in the eye and talk to them. Touch is important. I always ask when I have someone in clinic if it's okay if I touch them before I examine them, and I make them aware of what I'm going to be doing. You don't want to do any surprise movements because sometimes that doesn't go over very big. You want to look at the facial expression. And the woman on the bottom right-hand corner may be sleeping, or she may have pain somewhere and she's concentrating and trying to deal with that pain, or she may not know where she is and is confused about that. You also look at their personal appearance: clothes, hair, body scent, jewelry, tattoos, glasses, all of those things. And that can tell you quite a bit. So with these patients, we always communicate, but sometimes over 80% of the information is transmitted non-verbally. Nonverbal communication can support or contradict verbal messages. So you could have somebody, a family member, where they're looking as though they're upset and maybe leaning away from you, not looking at you, not communicating with you, and that can be right, or that's just the way they are. You don't know how they were when they didn't have dementia, and you just have to kind of figure it out as you go. Nonverbal communication often reveals our true feelings. And if you may come upon your family member in tears, or really angry, or laughing inappropriately at things, or being communicative. So you have to not always figure out what is the problem, but to sometimes go with the flow and not ask a lot of questions. All that does is confuse and frustrate them. And sometimes just sitting down by them and being quiet is helpful. Also, in practice, culture is a very big thing. And there are certain cultures that don't like to be touched, and you have to be really careful with that. Family customs. What position does that older adult have in the family? They may be the matriarch or patriarch of the family, and everyone has always done what they were asked to do by that person, and this is a big change. What the relationship is, if there's family members there, what their education is. I always ask families when someone is very confused, what were they like before? What was their normal personality? And race, ethnicity is another factor that you have to take into consideration. So there are strategies to work with, and we're going to move forward into that. You want to eliminate as much distraction as you can. So sometimes what can happen, the TV may be on, the grandkids may be around, there's noise, there's a lot of things that are that person is trying to deal with, and that can cause a lot of anxiety. Simplifying the surroundings, but always having something there that patient is familiar with is a good idea. You never come up from behind and put your hand on their shoulder or touch them. You want to approach slowly and from the front, establish and maintain eye contact. And you introduce yourself each time you speak, and that can be kind of strange as a family member, but to be honest, my mother had dementia, and at the end of her life, my sister and I would approach her and say, it's Patty or Leslie. So she'd have an idea. She could remember all her grandchildren and could identify them right to the very end, but her daughters, she couldn't do that all the time. You want to have good light, no shadows, because that can cast a shadow on someone's face and that can be scary. You don't have to talk to them like a child. You just want to use simplistic language and grammar and shortened sentences. And this is a really good example of what not to do. One is slowed speech. You want to speak slowly, but not so slow. That is very frustrating to the person. They don't know why you're talking to them like that. One of the things that I had difficulty with when I first started working with older adults is to ask one question at a time. I wanted to ask like 5. And then when I realized that wasn't working for me, then I began to change my behavior. Or if you're asking them to do something, just one instruction at a time, which may be as simple as, could you please stand up? Could you please walk with me? Whatever you're doing, make sure they can at least look at you and understand. You want to ask yes or no questions when you're trying to find out information. If you ask open-end questions, you can encourage emotional responses, but sometimes you really don't know what that patient is going, or what that family member or person is going to do. Sometimes if you ask a question, they may come out with language you thought they never knew. And it's quite, you can be taken aback by that. So you ask yes or no questions. You don't want to interrupt, even if you've heard the same story 15 times in 20 minutes. You want to be able to not interrupt and listen. And again, allow plenty of time for the individual to respond to you. If they can't find the word, patients with dementia can get very anxious, and you want to try and get them to describe the word they're searching for. And be willing to talk about the good old times. And sometimes you are very surprised at what that person's life was like. And we would do that with our pain patients, because once we understood the story, it was easier to take care of them. Personal memories are the ones most remembered, and as Linda talked about, they're better preserved. It's the short-term stuff they can't remember. Allow rambling. And as a healthcare provider, that's really hard. You want everyone to just answer your question and move on. And you can't do. It's opposite. You have to listen for keywords and themes. You may not understand what they're asking you, but if you listen, all of a sudden it dawns on you, they want to find maybe a clothing item, a shoe, or whatever they're looking for, and it takes a bit to figure out what they want. And you want to utilize memory aids with these patients, photographs, familiar objects. So those are all important things. You may have to repeat your question, but you have to use the exact wording that you used at first. And the person may only be able to grasp small parts of the question at a time. So in this picture, I can look at this person, and I've seen this look before. It's like, what the heck are you asking me? I don't understand what you're saying. You might want to try prompting, but no sudden movements. Maintaining a calm environment is important. And this is kind of repeating what Linda said about avoid correcting or trying to reorient them. And I mentioned this before, only one person should speak at a time. And actually, I found this out in practice when I would be talking and someone would interject. Sometimes we had to go back 2 steps or more to get back on track of what we were talking about. Smile. Avoid touching the person without first asking or explaining. And truthfully, I do this with every single one of the people I see in practice. I never touch them without asking if it's okay. The other thing is be prepared for sudden mood or demeanor changes. And sometimes all of a sudden the person is done with what you're doing with them. They don't want to do anymore. And at that point, the interaction typically ends. When you talk, don't put your hand up over your lips or put it on your face. It's hard for them to understand what you're saying. And again, if they have some hearing loss, they may be reading lips and they've been doing it for a long time. So you want to be able to have that remaining for them. Try to remain 3 to 6 feet away because you have to honor their personal space, and you don't yell or speak directly into their ear because that doesn't help and it agitates some people. You speak slightly louder. You don't yell though, because that hurts. If they have hearing aids in and you're yelling, that does really sound like you're yelling at them or you're angry at that person. You may hear comments about your hair, your face, your glasses. Don't take them personally. Patients sometimes have a tendency to just look at you, make a decision, and blurt out what they're thinking. And you don't want to get in an argument. That does not help, and it just makes people very anxious or upset, and you don't correct them because in their mind they may be thinking they're right. So good communication with family members and people that you know, it saves time. For a healthcare provider, it prevents mistakes. And when you sit down and actually use some of these techniques, family members relax as well. It reduces the potential for power struggles and abuse. And I think that goes for family members because it's, as Linda said, it's very frustrating when someone comes back to you every 2 to 3 to 5 minutes and asks the same question. It also, when you're using good communication and using these techniques, it prevents individuals from feeling helpless, and it reduces isolation and promotes personal bonding with family members. But also I've had patients who I've seen before, and they come in and I'll sit down and ask if they remember me, and they'll look for a bit. And when that recognition is on their face and they smile, that just means the world to me that they remembered who I was. If you're talking to them, and I always look if they've got, well, I'm a shoe girl, so some of my female patients have really good taste in shoes. And I will note cute shoes or a cute sweater or something, and that helps. And it reduces stress and burnout. So we want to thank you, both Linda and I, for listening to our presentation this evening. And I think that Dr. Crane is going to open it up for questions.
Thank you very much, Dr. Simons, and thank you both for presenting such a much needed topic. I thought the entire discussion was interesting, important, and timely for a lot of caregivers. We have quite a few really good questions coming in. So I see our first question here has to do with giving some advice. So the audience member says, can you provide advice for when you're a daughter or granddaughter dealing with a male grandparent or parent, and their pride doesn't allow for help, especially with toileting issues? They find communication difficult because of the discomfort and the dynamic.
Dr. Keilman, you want to go first?
All righty, so that is one of the very difficult issues related to caregiving. And part of it is that they want to remain dignified. They want to do the things that they were taught their whole lives that you do or do not do with children or grandchildren. And when their brain is incapacitated related to a dementia, they don't understand that you're trying to help. So sometimes it is helpful to get someone who is not related or a male relative to help with the situation. Sometime when they don't need to be using the bathroom, what you can do is sit down with them and talk to them about reminding them that they need some assistance, that toileting might be one of them, that you love them, you care about them, you want to help them to the best of your ability. And there are ways to actually help them that still protect their dignity and their humanity. And talk to them. You might have to talk to them about it a couple times, but you don't want them to get upset just before they need to use the bathroom, because then they could hurry, they could miss the toilet, they could fall in the bathroom. There are, and I saw another question is about caregiver resources. There is lots and lots and lots of caregiver resources. And in the handout that we have, the last entire page is about resources. I think that the Alzheimer's Association, even when a person does not have Alzheimer's dementia, they have so much help for caregivers. And there are also organizations for the top most prevalent dementias. There are also National Caregiver Alliance, and we have provided the link for you in the handout as well. And in Michigan, we have organizations. We have an Alzheimer's Association in the Lansing area. There's a state organization. So just have to do a little bit of researching, but we give you the main numbers in the handout, and they can give you tips and tricks. The other thing that I think is so important that I use with my individuals and their families is support groups. When you know you're not the only one experiencing it, whether you're the individual diagnosed with a dementia or whether you're the family member or friend or care partner, then it feels much better. And the great thing that I love, I talk to support groups regularly, is they share things that have worked for them, things we wouldn't even think about. And, you know, in healthcare, we care about evidence-based, but I'm sorry, when you're dealing with dementia, whatever works for that person is a blessing. So we have to remember that just because it worked on Jamie or Susan doesn't mean it's going to work on your person. But there's lots of things that we can try. So I hope that helped.
Thank you very much. Dr. Simons, this one might be a good question for you since you discussed communication. What is the best way to de-escalate the situation if your loved one becomes upset?
Some of it is just walk away for a few minutes, because if that escalates, you get upset as well. I have to go get a drink of water. I'll be right back.
Okay, so I'll just pretend I'm Leslie. So de-escalation can also be about diverting them. So if they're concentrating on something, try to get them to look or think about something else, or think about something that they like. And because of short-term memory, 20, 30 seconds, maybe that they will forget about it. But pushing it or doing all those never do this can just escalate the situation a lot more. And I think that the sooner you notice that someone is maybe getting a little bit upset, and that's where nonverbal communication, facial, body language, sometimes they'll clench their fists, then you know that it's probably a good idea not to, at this time at least, to pursue that. And I hope that helps.
I'm so sorry. I've been in meetings all day and just got a tickle, so I apologize.
Oh, no worries at all. Here's another difficult question. How do you approach a parent that may not be ready to admit that they may need to be evaluated for Alzheimer's or dementia?
Well, I can talk to that with my mom, because she was not a person who liked doctors. She was not a person who went to the doctor. And there were things that were going on that needed to be addressed. So I'm lucky in that my sister is a nurse as well. And we were able to sit down and ask her if there was things that she felt were different. Did she feel like she was forgetting things? And it's like, if anyone has ever talked to their parent about not driving anymore or taking the car keys away, you make small baby steps. You don't push it unless they're a danger to themselves. Then you have to kind of think of things to get them in. But again, it depends on your relationship with the parent. My sister is much closer to my mom than I am. She was her primary caregiver till the end of her life. So, and my sister could really just sit and talk and be clear, and really put a lot of work into it. So it's just a matter of doing your best.
Thank you very much. I think this other question is very closely tied to that, which is basically how you start the conversation, asking for advice on how you start the conversation. Who's the best person relationship-wise to initiate the conversation? And I know from my experience that's a very variable thing, and something that relies very much on cultural and family dynamics. I don't know if either one of you has anything else to add to that.
Yeah, I think it's very important that that the family talk about this sooner rather than later. And just because, we have siblings, or it gets to be such an impersonal, emotional experience, just because they've been in your life your whole life. And so sometimes you still look at us like children, or I'm not going to talk to you about this kind of stuff. Or they just are afraid. They're afraid because people know that if you're losing your mind, that's a really horrible thing. And they're thinking the worst. That's why I talked to you about potentially reversible causes for confusion. And it's usually, the caregiver is usually the oldest daughter or the daughter-in-law. It doesn't have to be. I think that I had two brothers. My two brothers, my mother trusted in them more than she did me. I didn't take it personally, except when she started like asking my brother, the minister, to help her get a walker. And of course, I didn't get the right kind. And then that was my fault. So, we have to understand, which is difficult, where they are in their own mind. And I think that talking about advanced directives, advanced care plans should happen, quite frankly, when a person turns 18, and it should be something we do on a yearly basis. But if you have those kind of papers drawn up, it's nice because it gives you a foundation in which you can talk about and what a person's hopes and values and desires are as they get older, or in an emergency. And sometimes we have to help the person understand that maybe it's not about them. Maybe I would feel better if you could go to a provider and just see how things are going. Maybe you're having, more issues during work around the house. So let's go and talk about that, and let's see. I'll go with you. And I wish there was recipes, but just like everything, it's all individualized, and it's really based on the person. And the sooner you could get them in, the better, because the earlier we can diagnose a dementia or do a workup, we can reverse some things, as in that one chart. And if they do have a dementia, as I mentioned, we didn't talk about and aren't going to talk about the pharmacokinetics. They don't cure the disease, they don't slow the disease, but they help with the symptoms of the disease. And so that is worthwhile too. And I really believe that I've had a lot of patients and their families tell me that on the medication, they felt their memory improved. And I believe if you believe something, sometimes that's all that really matters, because it makes everybody happier. So there's a lot of help online about this question as well, but it's very hard to get somebody to go someplace where they don't want to go because they're afraid of the information that they might hear. And it's always the worst that they're thinking of. And sometimes it's something totally different that we can fix. So I always try to come from it from, I'd really like you to do this. It's not about them. And that also be optimistic about what the findings could be. So I hope that helped a little.
Thank you very much. I'm hearing a lot of love and compassion coming in that answer, and approaching it from that perspective as well. Rather interesting question. Can somebody who excessively drinks beer and recently diagnosed with alcoholism stop drinking altogether as the dementia progresses? In other words, I think the audience member is asking, can you forget about substance abuse and addictions as dementia progresses?
Okay, I'll take that. Yes, you can, depending when that substance abuse or addiction started. If it was something that a person started when they were young, as their long-term memory takes forefront, they're going to remember drinking and enjoying it and things like that. It depends on the person. And there is alcohol dementia, and it needs to be diagnosed, and the person needs help stopping. It's not like if this has been a substance use disorder for a lot of their lives, it's really hard to stop doing something, whether it's smoking, drinking beer, alcohol, other drugs. But it's always worthwhile trying to help people develop better lifestyles and living habits, because things can get better. The brain cannot regenerate the death of cells. We don't know how to do that. So alcohol can cause death of brain cells, as well as conditions that lead to death of cells, the neurons, the connections between brain cells and neurons. So anything is possible. I think a good workup would be appropriate. I think for a person, if they have been accurately diagnosed with dementia while they are still have a substance use disorder, I think that puts them really at higher risk for a lot of other things, including a danger to self and others. So once again, I think that's something that you could call Alcoholics Anonymous about, that you could also utilize some of the organizations that we put into the handout for you. It's not easy. It's a battle, just like working with substance use disorders that individuals have who don't have dementia.
Right.
It's difficult, and it takes a village. It really does. And everybody has to be on the same side, not buying the beer, not serving it when everybody gets together, that kind of thing. So I hope that helps a little bit.
Yeah, absolutely. And if I may interject with my knowledge as well, and Dr. Simons as our resident neurology nurse practitioner, I think it's also important to remember that addiction pathways are a different kind of memory. Dr. Keilman, at the beginning of your presentation, did a really nice job of outlining sort of where these issues happen, and it's something that's unfortunately based and rooted in our reward system in our brain. And that my patients that I've had that have a history of substance abuse and dementia, they may not necessarily remember what they crave, but those cravings still sometimes exist, which can cause behavior issues as well, which is very challenging. But a really, I think, important question and a really insightful one from our audience member today. So thank you for sharing your knowledge at that. Let me see here. Next one is about a audience member here who says, my stepfather is in fairly advanced dementia and recently had a seizure. Is this common? He has been scheduled for an MRI, and what will they be looking for in that MRI?
When there's seizure activity, it depends on if the patient has, or the person has ever had it before. If this is new onset, they will get an MRI. They'll do other testing, MRA, which is a angiogram. So what they're looking for is if there has been any damage to the brain, such as bleeding, or you can have something called ischemia, when there is narrowing or clots in the major vessels and they're not getting enough blood or oxygen to their brain, and that can cause a seizure. They're also looking for any changes in the brain itself. And brain is composed of gray and white matter, and it's called that because it looks just exactly like that. But if the brain is smaller than it should be for the age of the person, if they're seeing other changes within the brain tissue itself, and they're looking for many different things that could cause it. It could be related to medication. and both Dr. Keilman and I, when we're caring for our older adult patients, do spend a lot of time looking at medications and seeing what that patient is taking, because there are a lot of things that either by themselves or in combination can create seizure. So blood work may be drawn. It may be something that whatever happened, they maybe ingested something that was toxic. Did they fall? Did they hit their head? Has there been an injury? So there are a lot of things that can cause that seizure. And when they do the imaging, they're looking for potential causes of seizure. And there's other testing that they do to look at, with a new onset seizure, the brain waves. They're looking at the formation of the waves in the brain, and that's called an EEG, where they look at that to see if there's any changes in that brain potential as far as nerve transmission. So there's a lot of things that come into play and a lot of testing that is done. Because a person, if they have advanced dementia, is not going to be able to tell them what happened or if anything happened.
Thank you so much. And unfortunately, I think that is all the time we have for today, but I appreciate everyone in attendance and also both of you for sharing your expertise with our audience members today. I know there's many questions that we didn't get to answer, but you may either email either of our panel members today. Their email addresses can be found at nursing.msu.edu. I'm sure they would be more than happy to get back with you for whatever questions you have. Thank you so much for spending the afternoon with us. I just really appreciate the time that you've spent today. Thank you very much. Everybody stay tuned for more information about the upcoming conversations webinars in the near future. And you can always keep in touch with the College of Nursing on social media. So have a good night and take care, everybody.
Thank you.
Thank
Bye-bye.
you. Bye.